Good afternoon, everyone. Now for the next session, I'd like to call Dr. Vakil sir and Dr. Anaga Vaidya ma'am as moderators.
Good afternoon, everyone. Now I call upon Dr. Sheetal Kabra ma'am for her talk on anatomy of secondary pulmonary lobule with role of radiology in diffuse disease of the lung.
Can we switch off the lights, please? Good afternoon, all. At the outset, I would like to thank the organizers for having me here. Now, see, everything in our body is very well organized. Nothing is haywire, be it TDLUs in the breast or hepatic lobules in the liver. So, and secondary pulmonary lobules in the lung. Everything is well organized. It's very pertinent as a radiologist to know the anatomy of secondary pulmonary lobule so that we can give a proper diagnosis and narrow our differential diagnosis. So, let's begin. What is secondary pulmonary lobule? It is the smallest structural unit of the lung which is bounded by the connective tissue septa. Smallest unit bounded by the connective tissue septa. It's polyhedral or hexagonal in shape and ranges from 1 to 2.5 centimeter in diameter. The secondary pulmonary lobule consists of interlobular septa at the periphery. It consists of centrilobular structures in the center and lobular parenchyma surrounding it. Now the interlobular septa, it forms the boundary or periphery of the secondary pulmonary lobule. It consists of two structures. The one which is highlighted in yellow are the lymphatics, and the one which is in red color is the pulmonary vein. Okay, so pulmonary vein and lymphatics are present at the periphery of the lobule. In the center, we have the centrilobular structure, that is the pulmonary artery marked in blue, and the black colored is the bronchiole. And surrounding these two, they form the bronchovascular bundle. Now the bronchovascular bundle is itself surrounded by its own connective tissue and the interstitium. And the third, surrounding this centrilobular structure, are the lobular parenchyma per se. Now, what is acinus? It's the portion of the lung which is distal to a terminal bronchiole supplied by the respiratory bronchiole or bronchioles. It is the basic anatomic and functional unit of the lung which takes part in the gaseous exchange. Okay, so the acinus, it consists of the respiratory bronchiole, the alveolar ducts, alveolar sacs, their interstitium and the vessels. So each secondary pulmonary lobules consists of 6 to 15 number of acini. So do we normally see secondary pulmonary lobule in normal healthy patients? No, we don't. It's highlighted only whenever there is some pathology. As in this case of interstitial pulmonary edema, we can very well delineate the anatomy of secondary pulmonary lobule. As you can see in the periphery, there are the pulmonary veins. In the center, you can see there's the artery and the bronchiole, and all the structure which is surrounding it in black color is the lobular parenchyma. Now that we know the anatomy of the pulmonary lobule, let's see how we can, on the basis of this anatomy, how we can assess the various pathologies on HRCT. Whenever there is any HRCT case, so there will be basic 4 dominant patterns. Either it will be reticular opacities, nodular opacities, high attenuation and low attenuation. That's it. So if we are able to really delineate what is the basic predominant pathology, it's very easy for us to categorize it into the different things. So let's first see what is reticular pattern. Reticular pattern is nothing but the web-like networking pattern which we see either on the chest X-ray or on the HRCT scans. It occurs because of the thickening of the interlobular septum. Normal interlobular septum is just almost 0.1 mm in diameter. So whenever it thickens, it results in the thickening. Now there are various causes of the thickening of the septum. It can be because of fluid, as we know that the septum consists of pulmonary vein and lymphatics. So whenever there is increased hydrostatic pressure and increase in the fluid, it can result in the thickening. Or it can be because of infiltration by cells, as in case of lymphangitic infiltration of the tumor and in cases of fibrosis. So these are the causes of the thickening. Now, how will it appear on the HRCT scan? This septal thickening can either be smooth, it can be nodular, or it can be irregular. Pulmonary edema, lymphatic tumor, lymphangiectasia are few of the causes which can result in smooth thickening. Whereas lymphangitic spread of the tumor. Perilymphatic diseases like sarcoidosis and few pneumoconiosis like silicosis can result in nodular septal thickening, whereas some fibrotic ILDs or sarcoidosis can result in irregular thickening of the septum. A note to be made here is that the lymphatic spread of the tumor can result in either the smooth or nodular septal thickening. So how do we differentiate it from pulmonary edema? In pulmonary edema, it will be generally bilateral, more dependent, and there will be associated ground glass opacity seen. Whereas the lymphangitic spread of the tumor is generally unilateral, and we also have the history of the tumor. So this is a case of the interstitial pulmonary edema, where we can see there is a diffuse, smooth interlobular septal thickening, and few areas of the ground glass opacity is also seen. Whereas in this case, we can see there is a nodular septal thickening seen in the right upper lobe. Okay, there are some thin and some septae appears thickened, and of note is made up of the metastatic nodule in the left upper lobe. So this is the lymphangitic spread of the tumor. Whereas in this case, if you see, there are multiple nodules which we are seeing along the fissures and the interlobular septae in the perilymphatic distribution, but also thickening of the bronchovascular interstitium, a case of the sarcoidosis. Now, whenever there is fibrosis, it will result and it will affect the interstitial fibers. So, in concordance with the secondary pulmonary lobule, there are 3 interstitial fibers which are seen. Then, we have the axial fibers which surround the bronchovascular bundle. And the third are the septal fibers which are surrounding the lobular parenchyma. Okay, so whenever there is fibrosis, there will be irregularity of all these interstitial fibers, which results in the distortion of the anatomy. There is thickening, which results in the loss of the architecture, that is architectural distortion. That is, the anatomy of the pulmonary lobule is lost. It has lost its polyhedral shape. Okay, and also there will be dilatation and pulling of the bronchiole because of the fibrosis, which we call it as traction bronchiectasis or bronchiolectasis. And associated with this, there will be thickening and irregularity of the intralobular interstitium, called as the fine reticulation or intralobular septal thickening. So, as you can see here, you can see the interlobular and intralobular septal thickening, which is present in the subpleural region of the right lung base. As you can see, there is a loss of the architecture, and there are fine reticulation, which are supposed to be the intralobular septal thickening. As in this case, you see that there is an irregular dilatation of the bronchus. We normally know that as we move from center to the periphery, the bronchus should reduce in diameter, and we should not see any bronchus near the pleural surface. But in this case, we can see that it is dilated and you can actually trace it. And there is irregularity of its wall also. So that is traction bronchiectasis. Okay. So interlobular and intralobular septal thickening in the subpleural region with traction bronchiectasis, in this case of ILD, probable UIP pattern. Now, what is honeycombing? So honeycombing is nothing but the stack of the cysts which we see in the advanced stages of the interstitial lung diseases. So for diagnosing honeycombing, they should be at least 3 in number. It should be present in the subpleural region. It should share the wall, and these are generally stacked upon one another. Now, what does this imply? Honeycombing imply the advanced stage of the disease, and it results in the extensive alveolar destruction. A note is made of crazy paving pattern. So what is crazy paving pattern? It is nothing but the diffuse interlobular septal thickening in the background of the ground glass opacification. Okay, as you can see, this is a normal lung, whereas this lung has increased attenuation because of the ground glass opacification, and superimposed on it are the diffuse interlobular septal thickening. Okay, so this is classically described in alveolar proteinosis, but please remember it's a very rare cause, and we do normally encounter it in pulmonary hemorrhage, pulmonary edema, infection, and other causes. Now let's come to the nodular pattern. Whenever we're talking of nodular pattern in HRC, in this context, we'll be talking about the small nodules, that is 5 to 10 mm in size, or micronodules which are less than 3 mm in size. So these nodules can either be centrilobular, perilymphatic, or random in distribution in accordance with the secondary pulmonary lobule. So infection, hypersensitivity pneumonitis, respiratory bronchiolitis are few of the causes of the secondary centrilobular pattern of the nodules. Whereas sarcoidosis, silicosis, lymphangitis, carcinomatosis are the causes of the perilymphatic distribution of nodules. Random nodules are the miliary nodules, which we typically seen in miliary infection like miliary TB or fungal infection, and MEDS. Okay, let's see these nodules one by one. So what is centrilobular nodules? Now as we know, what is present in the center of a lobule? It's the artery and the bronchiole. So these nodules, they are present in the center of the lobule. So when any airway pathology, any disease which is occurring through the airway, it will result in the centrilobular distribution of the nodules. So please see properly that all these nodules, they are uniformly spaced. They are just uniform in distribution, uniformly spaced, and they are seen away from the peripheral pleural margin as well as away from the interlobular septa. Okay, so these nodules can either be discrete, they can appear in cluster, that is rosettes, or sometimes you can also see a nodule surrounding the centrilobular bronchiole, and sometimes, or day in and day out rather, we see a tree in bud pattern as well. In this case, you can see there are diffuse, ill-defined ground glass opacity nodules studded in bilateral lung parenchyma. If you see these nodules, they appear equidistant from each other. They are seen away from the fissures, away from the pleural surfaces, and away from the septum as well. We don't see the septa, but we can make out from the anatomy. Okay. Now, if there's a history of allergy in this patient, this will be a case of non-fibrotic hypersensitivity pneumonitis. So remember, we don't use the term subacute hypersensitivity pneumonitis now. It is either fibrotic or it is non-fibrotic. Okay, so this was a case of non-fibrotic hypersensitivity pneumonitis. Similar pattern of nodules, if present in bilateral upper lobes in smoker patient, the diagnosis will be respiratory bronchiolitis. Same pattern of ground glass ill-defined nodules in collagen vascular diseases or in immune deficiency, the diagnosis will be follicular bronchiolitis. Okay, so it is the same appearance, but as you know, clinical history is very important. So that's how we can differentiate these nodules. As you can see here, these are the ill-defined ground glass opacity nodules which are seen surrounding the bronchiole. Okay, the lucent structure which is present in the center, it's the bronchiole, and surrounding which there are well uniformly spaced centrilobular nodules in case of follicular bronchiolitis in a known patient of the rheumatoid arthritis. Again here, you can see there are the clusters and well sharply demarcated. These are sharp margins. Okay, these are solid, sharply demarcated, clustered centrilobular nodules in the right lower lobe in a case of the bronchopneumonia. One subset of finding in centrilobular nodules is a tree in bud sign. So what is it? It means that there are linear or branching structure which is present, and at the end of which there is infective granuloma. So what is this branching structure? It is nothing but the impacted bronchus which is filled either with mucus, pus or fluid. And at the end of which there is a nodule, that is the inflammation, giving it rise to the tree in bud sign. So this sign, why is it important to understand this sign, is because it narrows down our differential diagnosis and it is almost exclusively seen in the infective process or in cases of aspiration. Okay, so that's the tree in bud opacity sign rather. So here in this case, we can clearly see beautifully demonstrated tree in bud pattern in a centrilobular nodules with the branching linear pattern giving rise to tree in bud opacity. Okay. Now the perilymphatic distribution. So as we know, where are the lymphatics present? Lymphatic is present in the periphery of the pulmonary lobule, okay, along the pleural surface, and it is also seen surrounding the bronchovascular bundle. So these nodules will be seen in this particular regions only, okay. They will be clustered either in the interlobular septum or in the pleural, along the pleural surfaces, or in the surrounding the central bronchovascular interstitium. So as you can see here, there's a very tiny, and remember this perilymphatic nodules are generally very sharply demarcated, okay. They're very sharp marginated. So you can see here that there is a nodular thickening and multiple nodules which are seen along the major fissure. There is also thickening of the centrilobular bundle, centrilobular interstitium, perihilar interstitium as well, in this case of the sarcoidosis. This nodular thickening of the septum is sometimes also called as a beaded septum sign. Whereas in this case, if you see, the nodules are seen at the periphery, okay. So they are seen as if they are arising from the pleura, okay, and they are very discrete. They are discrete, they are well defined, seen more at the periphery. So this is a case of a silicosis, okay, and in which you can see such well-defined nodules which are mainly present in the peripheral pleural surface. And how do we differentiate it from the sarcoidosis? As we saw in the sarcoidosis, it predominantly affects the perihilar and bronchovascular interstitium, whereas silicosis, the nodules are more discrete, obviously will have history also, but then they are also seen towards the periphery. We can also get, these nodules may also calcify, and we can also get the calcified lymph nodes. Then the random pattern, as the name itself suggests it. Okay, so these nodules are just randomly distributed. They are mainly micronodules, and you cannot ascertain any particular pattern to it. Like whether it is centrilobular or it is perilymphatic in distribution, we cannot really make it out. As in this case of Miliary-Cox, you can see multiple tiny micronodules which are studded in bilateral lung parenchyma. Other causes of miliary opacities are the infection like fungal, or rare causes like RCC and thyroid CA can also result in the miliary metastasis. Okay, so we have seen the nodules, and we have seen the centrilobular nodules, how they are very uniformly spaced, seen away from the pleural surfaces, whereas perilymphatic nodules which are seen in this along the lymphatic distribution, and random nodules which are just randomly scattered throughout the lung, and we have seen our differentials based on that. We'll just touch upon another pattern, that is the increased lung attenuation. Now increased lung attenuation can either be ground glass or consolidation. So what is ground glass? It is just the diffuse increase in the haziness, hazy pattern in the lung, in which the background parenchyma is not obscured, it's well maintained. Whereas in consolidation, it is the increased opacification of the lung with complete obscuration of the background structures. So this is a case of a diffuse alveolar damage, where you can see anteriorly there is increased in the lung opacification, but the background structures, that is the vessels and the bronchiole, they are all well seen. Okay, whereas in consolidation, it is the diffuse opacification of the lung where we cannot see the underlying structures. And here we can see there are the air bronchogram as well. Another pattern is the reduced lung attenuation, which is a topic in itself, so we won't be covering it. And there are multiple causes, like it can be lung cyst, even air trapping, honeycombing, bronchiectasis, emphysema. It can all result in the decrease in the lung attenuation. As in this case, this is a case of a centrilobular emphysema, in which the entire center of the lobule, this destruction, and it results in the centrilobular emphysema pattern. So just to summarize, in last few minutes, we have discussed about the anatomy of the secondary pulmonary lobule, and what are the various patterns which we see on HRCT. Then we discussed about the 3 patterns of interlobular septal thickening, that can be smooth, nodular, irregular, and multiple nodules, that is appearance like centrilobular, perilymphatic, or random distribution of nodules, and the differentials based on that. So my take-home message would be, if we know the anatomy of the lobule and if we can really ascertain what kind of predominant picture is there on the HRCT, and if we are able to extract the proper clinical details from the patient, like if there is any history of smoking, if there's any history of joint pain, so on and so forth, then we can really come to a diagnosis in most of the cases. Thank you for your patient listening. I would just like to quote Steve Jobs: stay hungry, stay foolish, never stop learning. Thank you.
Yes. Thank you very much, Mrs. Kabra, Dr. Kabra, for your detailed and minute anatomy of the bronchopulmonary segments and related pathology. You correlated very well. So it was a nice lecture, good information. And HRCT also you highlighted. It was what was needed today. Thank you.
Thank you, Sheetal, for a nice elaboration and depiction of all secondary pulmonary anatomy in detail for residents as well as clinicians. It was really useful because, you know, the pathologies are always in interstitial lung diseases. They are always in an overlap of all pictures. You need to differentiate with the pattern recognition only, and definitely with the clinical history, as everyone is stressing that point that we are clinical radiologists. So, but in diffuse interstitial lung diseases, it is the clinical history which will be the clincher for diagnosis. Thank you for a very nice elaboration.
Thank you, ma'am, for such a nice presentation. I request Dr. Vaidya, ma'am, to felicitate Dr. Sheetal Kabra, ma'am.